This video is about assessing the wheezy child with asthma. So this is children who have a diagnosis of asthma, say for example from a paediatrician, or it really also includes children over the age of 6 who present with wheeze, because as long as you're happy that it's not anaphylaxis or something else like an inhaled foreign body, this is probably a reasonable way to approach a wheezy child who's say 7 or 8. So by the end of this session, I want you to know what the initial management of severe asthma is. I want you to know what the terms burst and stretch mean in the context of mild to moderate asthma. And I want you to know when to prescribe steroids. So the key points are salbutamol given as 6 puffs if they're under 6 or 12 puffs if they're over 6. Via a spacer, always via a spacer, and it's often repeated every 20 minutes for 3 doses, and that would be considered a burst. So prednisolone is given to patients requiring admission at a dose of 1 to 2 milligrams per kilo. And I'll come on to that later in the presentation. Don't forget that wheeze can be other things like anaphylaxis or inhaled foreign body. And if you're not sure whether something could be anaphylaxis, then treat anaphylaxis. So what is asthma? Well, asthma is a bronchoconstrictive disease that is usually reversible and occurs in discrete episodes. So the constriction of the small airways is really important to remember, because it's this pathophysiology that provides the basis for all our treatment with things like bronchodilators like salbutamol, ipratropium, or with things like steroids as well. So the Royal Children's Hospital in Melbourne says that these 3 things are much more important in your assessment than anything else. So they emphasise the clinical appearance, mental state, and work of breathing. And I'll come on to each of these individually now. So the appearance is basically a gestalt. It's just from the end of the bed, does the child look like a well, happy child, or do they look really sick? And they place a lot of weight on your kind of feelings about how the child looks. The next thing is, do they have normal mental state? So are they alert? Are they conscious? Are they interacting? And then depending on their age, are they kind of engaging as normal, or are they floppy and drowsy and unable to speak? And then they also emphasise the work of breathing. So as I mentioned in the bronchiolitis video, the things we're looking at are tracheal tug, intercostal recession, subcostal recession, and then also things like nasal flaring and grunting. Don't forget that this could be anaphylaxis, and the times where you need to think particularly hard about anaphylaxis are, did the symptoms start immediately after a new food or medication, and were they very sudden in onset? And if so, that's got to raise suspicion for anaphylaxis. And if you're not sure, you should just treat with adrenaline, because if you don't treat anaphylaxis, it's fatal. Think about inhaled foreign bodies as well. Obviously, the older a child gets, the less likely this is. And once you get to school-age children who can speak and communicate well, then they can just tell you whether they inhaled something or not. But in younger children, it's something to think about. So, salbutamol given as 6 puffs if the child is under 6, or 12 puffs if they're over the age of 6. And if they've just got mild asthma, that might be all you need. You just give them the 1 dose and then see how they go. But if they've got moderate to severe asthma, you give them what's called a burst, which is you give them 3 doses, 20 minutes apart. So they get, say they're, for example, 7 years old, they might get 12 puffs for our spacer, then 20 minutes later another 12 puffs, then 20 minutes later another 12 puffs. And the rationale for doing this is that you basically load them up with lots of bronchodilator and then see how they go. And that period is called the stretch. So if, for example, you have your 3 doses of 12 puffs of salbutamol, and then you don't need any more for 3 or 4 hours, and you're nice and happy and your breathing's good and you don't have increased work of breathing, and we'll assume you've also got normal oxygen saturations, then it's a good sign that your disease is not too severe and you're probably going to be able to go home at that point. However, if you need more treatment after an hour because of your increased work of breathing, or you're starting to look more unwell again, then that can be a sign that your disease is more severe and you're more likely to need admission. So this stretch period is a gauge for how much salbutamol that child's lungs need to be functioning well and have nicely bronchodilated airways. So who needs steroids? Now this is a bit of a contentious topic, but I'm going to say for the sake of argument that if you need admission, then you need steroids. And there's been a few studies looking at, is there a benefit of giving steroids to children with only mild exacerbations? It's much less clear. I think for the sake of this argument, I'm going to say if a child is unwell enough to need admission, then they need steroids. And if they're well enough to go home, they probably don't. You may see some clinicians varying from that practice a bit, and that's completely up to them. But I think if you're new to this topic, simple rule of thumb is if the child's unwell enough to need admission, then they get steroids. So who can be discharged? Children that have mild to moderate asthma and can be stretched successfully, so they can go 3 hours after their burst therapy without needing any further bronchodilators. They're well enough to go home, they can be monitored. But you also need things like, you want them to have a safe discharge plan. They should ideally live close to the hospital. They should have, parents that are able to take them into hospital if needed and able to monitor them, and then they don't have risk factors for severe disease. So for example, if a child was born very premature and has lung disease, or they've got significant long-term health problems, or they come from a home with a lot of cigarette smoke, then all of those things might suggest that the child should be admitted because they're not as safe to discharge. So the key take-home points from this video are: salbutamol is given as 6 puffs or 12 puffs, depending on whether they're under 6 or over 6. It's always given via a spacer, and then it's often repeated every 20 minutes for 3 doses, and that's called a burst. Then we give prednisolone at a dose of 1 milligram or 2 milligrams per kilo to children that need admission. And don't forget the other diagnosis. You don't want to miss anaphylaxis. Don't forget inhaled foreign body. And if you're unsure about anaphylaxis, treat it because it's fatal to miss.